Hello, my name is Dr. Paul Richardson and I'm here to provide key insights to this excellent myeloma session that we've had here today in New York City as part of great debates in hematology. It was my pleasure to work with Dr. Ed Stadtmauer, Dr. Ruben Nazwiski and of course to our chairperson, Dr. Suzanne Lench, in a really, I thought, very interactive and dynamic session discussing a variety of aspects of myeloma management. In first instance, Suzanne provided us with a beautiful overview of how we define risk in myeloma, particularly in newly diagnosed patients, and how in that context we adapt therapy for each particular patient's needs. And what she framed very nicely, I thought, was the value of 3 drug regimens in the upfront setting on the one hand, the integration of antibodies as well into that platform based upon current data, recognizing that we're awaiting with keen interest the results of a variety of phase 3 trials, but at the same time we're recognizing the real value of these combinations in treating patients at higher risk. At the same time, she also framed the discussion around what standard risk patients might benefit from, and I think where we were left in terms of discussion was that standard risk require a triplet, and higher risk patients similarly absolutely require a triplet, but possibly consideration to additional strategies as well, including considerations to monoclonal antibody therapy, and of course in certain patients who are transplant eligible, using transplant perhaps earlier, keeping it in reserve for other patients, and at the same time integrating some of the newer treatment strategies to optimize outcome. So with her framing high-risk disease, I was then asked to provide some insights into some of the advances being made with small molecules or novel small or next generation small molecules in the treatment of myeloma, and was able to shed light on some of the exciting data around venetoclax, for example, selinexor, a fascinating next generation cytotoxic called melflufen, and then also some of the next generation IMiDs, as well as other potentially exciting new avenues, including HDAC inhibition. Now, with these small molecule approaches showing such promise, I think their ability to then be added to existing platforms is particularly exciting. And for example, the even more potent new IMiDs that are now entering early phase trial, I think show real promise, particularly if one considers them as partnered with what Dr. Ed Stadtmauer followed with, which was a fabulous overview of immunotherapy and monoclonal antibody treatment in myeloma. What Ed did was focus on elotuzumab, daratumumab, CAR T therapy, and in particular targeting BCMA. He then looked at antibody drug conjugate treatments with weaponized antibodies where BCMA is the target, but the drug conjugate obviously provides the cytotoxic punch that then is delivered to the tumor. And in that same context talked about other newer strategies in the future, including bispecific antibodies that may show promise. And I think when one thinks about that in the entirety, it was a particularly exciting session. We also talked about the position of transplant and could it be kept in reserve for some patients. Another key takeaway was the importance of maintenance and continuous treatment in keeping disease under control. That was then followed by a switch of gears into the relapsed refractory space. And what do we then do when patients have had optimal initial treatment, maintenance until progression and/or intolerance? What then happens if disease comes back? How do we best salvage our patients? There's a very important debate between Suzanne and Ruben looking at 2 central questions. We know that 3 drugs for sure in the relapse setting matters. Doublets can be used selectively, but really 3 drugs have now become a new standard, as reflected by numerous clinical phase 3 trials where 3 drug platforms have been shown to consistently show benefit compared to their doublet controls. Suzanne, I thought, framed that discussion very well, and I think in that context a 3 drug platform in salvage clearly makes sense for most patients, recognizing that doublets may apply in certain settings as well. Ruben, I think, had the more challenging task of explaining why you might think of 4 drugs, in other words, a quadruplet. And whilst we don't necessarily have large phase 3 experiences to guide us there, we do have a number of early phase studies that suggest 4 drug platforms are feasible and can be considered, particularly in patients with aggressive or resistant relapse, where a combination of drugs becomes very important with non-overlapping toxicities. So I think Ruben framed that very nicely. He also spoke a little bit about chemotherapeutic approaches in the setting, including such combination chemotherapeutic strategies such as DSAP or VDD-PACE. But I think the audience and certainly the panel agreed that these approaches, whilst occasionally very active, can be challenging in terms of side effects, particularly in terms of cytopenia and infection, and one has to be therefore aware of the limitations to their use. The good news is that we have other quadruplets of biologically derived treatment, a monoclonal antibody, an IMiD, a proteasome inhibitor, a steroid, and an appropriate fifth or fourth drug partnered into that to provide some sort of additional therapeutic advantage. And these combinations have the promise of not only being more active, but also far better tolerated. So I think we were left at the end of the discussion on relapsed refractory disease with a very strong message that combination strategies of next-generation proteasome inhibitors, IMiDs, other small molecules, and most importantly antibodies, are now there for us to salvage our patients after initial treatment may have failed them. So the overall context of the discussion ended, I think, on a very positive note, which was to recognize that current long-term data on median survivals from important studies such as CLGB 100-104, the so-called Alliance study in which len maintenance was tested, it was very encouraging to hear that in that study, median overall survival for those patients on lenalidomide maintenance was a staggering 10 years. And I think that reflected very favorably on where the field is moving, particularly when one considers the excitement and promise around salvage strategies that were beautifully laid out for us by both Suzanne and Ruben. So all in all, a very exciting meeting, comprehensive, lots of exciting new avenues and directions to pursue, and at the same time some very practical guidelines regarding symptom management and the care of patients day to day in both the academic and community setting. Thank you very much indeed.